Welcome to the Methodist Grand Round Series. Our guest speaker today is Dr. Abby Delaney. She's a reproductive endocrinologist with Parkland Center for Reproductive Medicine. She was born and raised in Omaha, went to medical school and residency here at UNMC, and fellowship programs in reproductive endocrinology and fertility at University of Louisville and Mayo Clinic. She'll be presenting on surgical management of endometriosis-related infertility. Please welcome Dr. Delaney.
So nice to see everybody here today and online. Hi, everyone. So thank you so much, Dr. Summer-Sheely. I was asked to come and do this talk. I've given this talk before about a year ago at a Grand Rounds and just updated it based on some kind of data that was presented at ASRM. But ultimately, I think it's kind of important, particularly for the generalists in the room, to understand that I think our management surgically of endometriosis has really changed in the last probably 20 years. Just even since my residency, I think we're doing things a lot different. And so when someone asked, like, what would you like to give Grand Rounds on? I was like, well, I feel like for my own knowledge, I need to update myself. So that is why I chose this topic. So anyways, it's very nice to be here. So I don't have any disclosures. I've been waiting for 25 years to have disclosures. So, you know, I think that the three main objectives that I want everybody to get out of this is that I really want everybody to understand the mechanisms behind endometriosis and why they can be associated with infertility. There we go. I want to understand the difference between the stages of endometriosis, and I think this is a really fundamental take-home point that I'll sort of explain. You can't totally stage endometriosis by ultrasound, but there are some little tips and tricks that REIs use all the time. And then I want everyone to sort of understand the importance, and I think this is paramount, of offering fertility preservation prior to surgery for endometriosis-related pain. And so we'll kind of go on the journey on sort of like, when do we take these patients to surgery versus when do we offer them IVF? So it's, you know, background population, it's estimated that 25 to 50% of women with infertility have endometriosis. In the infertility population, that's probably 6 to 8 times higher. And 30 to 50% of women with endometriosis have infertility. And that's a really amazing point, is that only 30 to 50% of women with endometriosis have infertility. It's probably a lot more pervasive than we see, but, you know, obviously in my population and in Rachel's population, we see it more frequently, but it's not equative, right? So it's not like if you have endometriosis, you're going to have infertility, or if you have infertility, you have endometriosis. But there's a reasonable body of evidence demonstrating that there is an association between endometriosis and infertility, but it's unclear exactly what causes it. So what might cause it? You know, I always tell patients it's probably a combination of a couple things. Number one, distorted anatomy. Anybody who's been in these abdomens knows that there is really, you know, there's a lot of scar tissue, there's a lot of inflammation. You know, ultimately, there's a lot of studies demonstrating that there's altered peritoneal function. Women with endometriosis have increased volume of peritoneal fluid, and in that peritoneal fluid, there's a lot of increased concentrations of prostaglandins, proteases, and inflammatory cytokines. That was what my whole thesis in fellowship was about mouse model endometriosis and kind of showing the difference between the two. It's unknown whether or not epigenetic alteration of these inflammatory markers is what causes the endometriosis, or if it's caused from retrograde menstruation. You know, there's the somatic cell theory. There's a lot of different kind of variations in sort of why endometriosis exists. We don't know exactly, but we do know that women with endometriosis, their immune system acts very differently in their abdomen than in women without endometriosis. There also does appear to be ovulatory abnormalities. Is it that when they're trying to ovulate, they don't actually release their egg? Is it because of decreased prostaglandin kind of abnormalities that they just don't actually kind of have that ovulatory function? There are altered hormonal and cell-mediated function. There is impaired implantation. a lot of the new data you might see from our patients coming back is that there's microscopic endometriosis that lives at the level of the endometrium. And obviously, we know very well that you can't go in and like surgically resect the endometrium over and over and over without causing scar. Most of the data would indicate that if you treat women with Lupron for 2 or 3 months prior to an embryo transfer, you really knock out a lot of that kind of microscopic and endometriosis that exists in the endometrium and increase success rates of IVF. We use, you may see this kind of in our notes and things, there is a new test called a Receptiva. It's been out for 4 years. And it evaluates for a marker of inflammation called BCL6. And when it's elevated, there is either it's either dilated fallopian tubes, so hydrosalpinx, or endometriosis. And so as long as you've evaluated the fallopian tubes and you know that their tubes are clear, if they have elevated BCL6 measures, we usually treat with Lupron for a couple months. And then I think, I always tell people with endometriosis that, just patency doesn't equal function. So like if we do an HSG and their fallopian tubes are open, that doesn't always mean that the inside of their fallopian tubes is working well. So there can be impaired tubal transport from that inflammation that occurs. And so, the bottom line is it's just important to sort of know that the inside of their fallopian tubes, which you really cannot access, may not be working well. And so that's why IVF is sometimes really beneficial for those patients as far as sort of tubes. And then I think the biggest thing that we sometimes see is that a lot of endometriosis associated infertility is from prior surgeries. So, somebody going in trying to sort of like improve their pain control, somebody going in to try to help fertility, and then, damages their fallopian tubes, decreases their kind of ovarian reserve by removing a lot of the endometriosis in their ovaries. And so, part of the reason I wanted to do this talk is just to sort of like, these are patients that, it's a highly vulnerable population when you're talking about infertility patients. So before we go kind of, I was raised in the to cut is to cure type thing. But before we go kind of like cutting everything and making sure that sort of we clear their pelvis, let's really sort of like take a look at what their overall goals for fertility are. I think what is really interesting is I think in our field, there's a lot of kind of talk as is there different kinds of endometriosis, right? Is there kind of fibrosis associated endometriosis, which is like scar tissue, and then is there inflammatory endometriosis, which is more like endometriomas? And I think we all sort of like gutturally feel like there's a big difference. There's 2 different kinds of endometriosis, but I think it's important to sort of understand that the biggest endometriosis that I worry about as a fertility specialist are endometriomas. So when you see a big cyst on their ovary that is classic and consistent with endometriosis, I always start worrying about diminished ovarian reserve, inability to complete their childbearing. Those are the things that should go through my head and should go through all of your heads when you see them just on kind of routine scans. There's 2 reasons why endometriomas themselves cause kind of infertility. I think the biggest thing is that it's space occupying. It's taking up space. And so if it's taking up space and it's kind of covering other follicles, it's very hard for follicles to be in a place where a big ovarian cyst is. I think the other thing is that there's so much inflammation in that kind of cystic structure. That cystic structure actually causes oxidative damage to the surrounding follicles. And that leads to kind of increased atresia of normal eggs. So classically in these women, a lot of women, if they don't have associated PCOS or associated high antral follicle counts, you're going to see DOR, so diminished ovarian reserve, in these patients with endometriomas. And it's because of these kind of massive endometriomas. And so, I think it's really important if we go in there, again, back in my day, back in residency, we used to resect all of these. We used to strip the endometriomas. We should do all of these things. Just recognize that if you're going in and you're removing one of these cysts, it has already caused damage to the ovary, period. It's already decreased number of available antral follicles. And by going in there and resecting it and kind of damaging it, whether or not you're doing thermal damage to the ovary, whether or not you're stripping it more, you're causing more damage and you're decreasing their antral follicle count even more. And so we have to be really cognizant when we take these patients back to surgery on what our goals are. So reminder of staging on endometriosis, there's a point stage that is assigned. So stage 1 is minimal, 1 to 5 points. Stage 2 or mild is 6 to 15 points. Stage 3 or moderate is 16 to 40 points. And stage 4 or severe is greater than 40 points. This is the kind of like fun trick that REIs use all the time. If you have an endometrioma, which you can diagnose by ultrasound, you're already at 16 points. So you are already at stage 3. So by definition of having an endometrioma, you are already at stage 3. So you already have advanced stage endometriosis. And so when you see these people on ultrasounds, I think that just sort of heightens kind of your awareness of like, I need to treat this person a little differently than the unexplained infertility with normal ovarian function who appears to have normal ovaries. So these are the people that probably need more aggressive therapy, maybe referral to an REI sooner. And the bottom line is it's just because they have advanced stage disease. Scar tissue encasing greater than 2/3 of the tube or ovary is also considered 16 points. So if you do an HSG on these patients and they've got what appears to be sort of like a big hydro plus an endometrioma, again, already stage 3 or. So this is really sad. There's only been 2 randomized control trials in all of history that have evaluated the effectiveness of laparoscopic surgery for stage 1 or stage 2 endometriosis. Again, going back to ultrasound, these would be people that we can't diagnose on ultrasound. So their ovaries look normal, maybe their fallopian tubes look normal, but the bottom line is for only stage 1 or stage 2, there's only 2 randomized control trials. And so the first one was done in 1997, and I think a lot of us trained during this time period where back in the day when surgery was really kind of like a thing for endometriosis. We were like, yeah, we're gonna go take it out, we're gonna burn it, we're gonna cut it out, we're gonna do all these things, and we're gonna help these people get pregnant. And it came a lot from this data, right? And for about 10 to 15 years, that's a lot of what we did was we went in, we cut out, we did all these things. So in 1997, there was 341 with infertility and stage 1, 2 endometriosis, aged 20 to 39 years. And they were randomized either diagnostic laparoscopy alone, just peek, look, bye, versus actually excising and ablating. And the outcome of interest, which always is in any REI study, was live birth. And treated 30.7% versus untreated 17.7%. It was statistically significant. And so everybody was like, okay, we need to go in and clear out all the endometriosis. Yay, sounds good. The second study was in 1999. Again, 2 years later, these 2 studies have sort of defined an entire generation of OBGYNs that are saying we should be operating on all these endometriosis patients. 101 women aged 36 or younger randomized to diagnostic laparoscopy versus excision ablation. Again, live birth outcome, and they didn't see a statistically significant, but they didn't feel like it was powered enough to make that statistics significant. And then ultimately, it was planned to detect a 2.7-fold higher live birth rate. And this study also tried to sort of evaluate in secondary analysis whether or not it was beneficial to excise versus ablate. So I think that it wasn't as well a designed study as the first one. But still, I think that there was some kind of controversy at this time, as which it was okay, well, we have one study that shows that it has a great benefit, and we have another study that shows that it's really equivalent. So then a meta-analysis just, was done, and it took the 2 randomized control trials and combined all the data. And the absolute difference is 8.6% in favor of therapy. The number needed to treat is 12 for women with stage 1 or 2 endo. But remember, if you're just, how many women have endometriosis? The prevalence of endometriosis in women with infertility is around 30%. I always tell people, if I can't diagnose endometriosis by an ultrasound, meaning I can't see an endometrioma on your ovary and your fallopian tubes look normal, in order to get you pregnant, I would have to do 40 surgeries. The number needed to treat is around 40. So you'd have to do almost 40 surgeries to get one person pregnant with early stage endometriosis. And I think this is what's the really important sort of take home point is what does this mean for kind of unexplained fertility? Unexplained infertility is defined as normal ovarian function, normal labs, normal HSG, normal semen analysis, open fallopian tubes. If they have unexplained infertility, I tell these patients, 30% of you may have endometriosis. And 20 years ago, we may have taken you to the operating room and we may find it. And we may ablate it, and the likelihood of getting pregnant from one of those kind of surgeries is low. In order to get one person pregnant, I'd have to do like 40 surgeries, which, as we all know, we're not doing 40 surgeries a year for stage 1, stage 2 endometriosis. So I think a lot of the data after this meta-analysis came out, everyone's like, okay, we're going to excise endometriosis. We're going to tell people it's an option. Particularly, in the 90s, IVF was not good. Even in the 2000s, IVF was not good. And so ultimately, then people started to say, okay, let's talk about excision versus ablation. So, a lot of my partners, I don't do a ton of endometriosis surgery, but my partners do. And most people still use ablation, either with a laser. But, I think a lot of the mixed folks around the country are doing excision. This was a study that was done in 1998. It was only retrospective, and really they did not see any difference. Okay, so then follow-up studies. ESHRE talks a lot about, so ESHRE is the European Society for REI. It's kind of like equivalent of ASRM. Talks a lot about a meta-analysis, but there was really only one study who published which compared IVF outcomes in those who had surgery and who had not. So this is kind of the only study out there. It's a group of 399 women with minimal to mild endometriosis. All visible endometriosis was completely removed prior to ART. In the control group of 262 women, there was only a diagnostic laparoscopy that was performed. In the group in which surgery had taken place prior to ART, there was significant higher implantation rates, pregnancy and live birth rates. They had shorter time to pregnancy and higher cumulative pregnancy rates. So could be beneficial for IVF. So if you're going to do surgery prior to IVF, it could be beneficial. But follow-up and meta-analysis basically state that that it's really equivalent. So should we take all these patients with unexplained infertility, try to figure out whether or not they have endometriosis and then do IVF, or should we just go straight to IVF? And so most of the data kind of moving forward has demonstrated that in women with kind of early stage endometriosis, there's really no differences in live birth rate, clinical pregnancy rate, or number of eggs retrieved. And so most of our societies, ASRM, as well as ESHRE, state that clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in the setting of early stage endometriosis. So I think the take-home point from all this is if you've got someone with unexplained infertility, you do not need to sort of just be like, well, let's go take a look. I think that is kind of an old school thought. I don't think that any reproductive endocrinologists are really doing that anymore. But part of the reason kind of all of that came about was these early studies from the 90s that demonstrated this possible benefit. Okay, so that's kind of like the breakup point in the talk between sort of the early stage endometriosis, stage 1 or 2 that you can't really see on ultrasound. This is when we sort of divide off and say, okay, now we've got really bad endometriosis that you can either see by ultrasound or know by history. So the following parts of the talk are divided into sort of 3 different categories. So if I do surgery on these people, what are their spontaneous outcomes? So what can I counsel them on sort of what is their benefit of doing surgery? And then I'll talk a little bit about IVF outcomes following the surgery. And then I think, the biggest one I'll talk about is that, in probably if you lined up 10 reproductive endocrinologists and you'd asked every single one of us, if you saw stage 3 or stage 4 endometriosis, would you offer IVF? And 9 out of 10 say absolutely. And it's because of a lot of the things that we already talked about before, the associated peritoneal abnormalities, the tubal abnormalities, the dysfunction with the ovary, the inflammation. If you're taking those eggs out of the body and you're fertilize them with sperm, you're fixing the problem, which may or may not be able to be controlled with surgery alone, which I'll talk about in a minute. So first, looking on data on spontaneous conceptions following endometriosis surgery, breaking this down into the presence of endometriomas and rectovaginal disease. This was looking at patients with stage 3 or 4 endometriosis, and basically looking at a lot of the meta-analysis in history. So we know that you basically go in there, and if you resect the endometrioma, the spontaneous pregnancy rate is about 50% from 13 to 94 months. So like women at age 37 with advanced stage endometriosis don't have 94 months to wait to build their families. So if you go in there and like gonna hero it out and you're gonna resect all this endometriosis and we're gonna get you pregnant, like the answer is highly unlikely. Like, I mean, it's 50% with over a year of attempts. So I think that is like the take home message right there, is that like, if you see an endometrioma, resecting it is not gonna give them a very high pregnancy rate. But the caveat on this study, which is absolutely true, is that many studies did not include women who had previously tried to conceive or had like prior history of pregnancy. So this is, primary infertility, with an endometrioma. This is only one study. It was an observational study of 825 patients suffering from endometriosis-associated infertility with stage 3 or 4 cystic endometriosis with endometriomas. In all cases, endometriosis was the major factor for infertility. Laparoscopic surgery was used to treat 483 patients. And then it was what was done at surgery was cystectomy whenever possible. And the follow-up of the patients continued kind of for several years. So ultimately, expectant management, so you do surgery, you wait, you allow these patients to try to conceive. Over 8 years, only 11.8% of these couples try to conceive. In the same series, surgery was followed by a conception rate of 54%. If you did like ovulation induction. So, and that was over 13 to 15 time months. So, I think this is the case where they can't afford IVF. They need fertility treatment. I don't want, I think their success rate is less than 5% continuing on their own every month. But if I go on there and resect things, and then we do some ovulation induction, over a period of time, about 13 to 15 months, we may have 50% success rate, which again is abysmal. But I think every patient deserves the ability to sort of like make their own personal decisions regarding their family planning. And so those are things that I talk about with patients. The average time to pregnancy in women less than 35 was 11 months, and greater than 35 was 6 to 7 months. And you can see that it plateaus after 20 months. Kind of my fast rule is when I ask people how long they've been conceiving, if it's 1 year, I always say, about 85% of couples will conceive within the first year of trying. If it's been 2 years, it's 95% of couples will conceive within the first year of trying. So if you're beyond 2 years, if you've been trying for 2 years, you're in the less than 5th percentile of all couples. And so that's where I really start saying we need to be aggressive. Like these are people that really have bad infertility for whatever reason. And so I think that this data, kind of correlates with that. And so, so there's no, of course, this is classic REI, there's no randomized control trials evaluating the effect of surgery in subfertile patients with like rectovaginal endometriosis. So, there's a lot of data out there, like people are being able to diagnose rectovaginal endometriosis by MRI. To be fair, I don't routinely use this. I don't really see pelvic pain patients. I think if we had a MIGS provider in the city that was really kind of working on treating pelvic pain for endometriosis, we might be seeing or hearing a lot about rectovaginal disease and how to treat it. But ultimately, if you resect it, like the spontaneous pregnancy rate in women with infertility is 24% over 3 years. Again, like it's abysmal. Surgery is just not super effective in these patients. This is a little bit more common with the vaginal disease, is that, you know, extensive surgery doesn't appear to be superior to a conservative approach, i.e., you know, excision, ablation, and or medical therapy. So that is kind of a little bit of data on sort of, okay, you take somebody back, you know, make their pelvis look pretty, and, you know, what are their success rates? Just, they're bad. It's not good. And so what if we are going to kind of do surgery and then do IVF? The impact of ovarian endometrioma, so kind of removing those endometriomas, it's really controversial. There's no randomized control trials that exist. So meaning that you take these same patients back, you resect all their endometriosis, then you take them to IVF. Two meta-analyses don't demonstrate any benefit on live birth rate, but women who had a lower antral follicle count prior surgery required higher doses. Again, it's kind of to highlight that like the endometriosis itself is going to cause lower number of eggs, and that would make me highly risk adverse to going in there and resecting more. It's just going to diminish their ovarian reserve even more. In a retrospective cohort study, there was no difference in live birth rate, but there was a higher likelihood of cancellation in the endometrioma excision group. So that's why you'll see a lot of us, we don't go in there and remove the endometriomas prior to doing IVF. We just work around them. We don't enter the endometrioma during IVF, so we don't stick a needle in them if we can avoid it. But the bottom line is most of us, unless they're gigantic, unless we're worried about cancer, there's, you know, very odd, normal appearing signs in the ovary, we'll just leave them and work around. This is just the only other study that there is on surgery for stage 4, stage 3, stage 4 endometriosis followed by IVF. It was a prospective study. It's only 64 women with 1 endometrioma, and then assessing IVF response or outcome in women with this. And there was essentially a lower number of eggs retrieved with the affected ovary with the endometrioma was the most predictive factor. So, you know, the big question I always ask myself is, if I go in there and resect it, am I going to increase the number of eggs I retrieve? And a lot of that depends on when I look at an ultrasound and I see the antral follicle count of the number of eggs surrounding the endometrioma. I really count and pay attention to sort of how many there are. And if I feel like there's a lot, then I really don't go in there and resect. If I feel like there's really minimum and that endometrioma is really pushing out on the capsule and I feel like I can really kind of get in there and sort of like decompress that ovary and really improve the number of eggs I retrieve, then I may go in there and take it out. I think I do that maybe once a year. But it's, you know, it's a very personalized approach to care. Like every patient is different. Every endometrioma is different. There's multiple factors that go into sort of decide whether or not these patients need IVF, whether or not they need surgery, whether or not I can even attempt IUI. And so that's why I think if you see an endometrioma, these are the patients that really need to be sent on. So this is the kind of, I just wanted to add one slide on here. Again, I don't do a lot of these surgeries, and you know, I don't think there's really anybody in Omaha that does a lot of the deep infiltrating endometriosis surgeries. But you know, if there is colorectal surgery, they did show a small increased pregnancy rate of surgeries performed prior to IVF, that in spontaneous pregnancy. So if these people have stage 4 endometriosis, obliterated cul-de-sac, colorectal disease, they need IVF. But the problem is that the surgical risk of these surgeries, when you have these deep infiltrating endometriomas with risk of colon damage, ureteral damage, all these things are so high that most of the data say that it is not beneficial to go in there and remove it if you're only treating their infertility. The only reason that you would go in there and resect and really remove all of their endometriosis is for pain, but certainly not for fertility. And it's because these surgeries are so high risk and it doesn't increase their success rate. What about repeat endometriosis surgery? So for infertile women who have stage 3, stage 4 endometriosis and have previously had more than one infertility operation, IVF is better. It's not been addressed in a randomized control trial, but for, ultimately, there was one retrospective study of women with stage 3, stage 4 endometriosis who underwent IVF and then repeat surgery. Pregnancy was 70% after 2 IVF cycles and only 24% within 9 months of trying if they did surgery. And so, we tell people if you guys can look at this. I use this every single day, but SART, so www.sart.com, has all of our national CDC data on IVF. In women under age 35, their success rate at a reputable clinic should be right around 55 to 65%. And that's in one cycle of IVF compared to 24 to 50% over 2 to 3 years of trying. And so it's dramatically more efficient. The other benefit that I feel like in these patients that do IVF is, particularly if they want more than one child, like it really affords them the ability to sort of preserve their fertility for future use. I think if there's ethical, religious, any of those kind of concerns with IVF, we just freeze eggs and we can kind of limit the number of eggs that we fertilize per time, so that they don't have embryos left. There's a lot of flexibility in how we do that because we've gotten so good at egg freezing. So I think the take home message of all of this is that surgery is just not really effective for advanced stage endometriosis. I think the final thing that I sort of want to talk about is, my presentation was focused on sort of surgery and fertility. What I didn't focus on is surgery and pain. And what you guys see as generalists, you do see a lot of chronic pain. And I do think there is benefit for resecting endometriosis for pelvic pain. What I would say though in these patients is that if you're going to resect or ablate endometriosis for pain, or let's say you incidentally find an endometrioma on kind of scan, these are patients that you need to have a family planning conversation with them. They're 25 and they've got an endometrioma and they're not partnered and they're not thinking about kids. Like, these are the people that probably need to come to see us to sort of look and see whether or not they would want to do an egg preservation. Just because they're at high risk for having diminished ovarian reserve later in their life and then not being able to complete their family of their dreams. They recently did a study that was presented at ASRM that looked at when we cryopreserve eggs, how many women actually come back to use them. And the number was actually low. It was only about 10 to 20% come back to use them. But in the endometriosis-related people, it was 70 to 90. And so, I think you guys see a lot of these patients that, have these advanced stage endometriosis that are coming to you at a young age, and they're diagnosed, unfortunately, very young with advanced stage disease. And what's really sad is that, a lot of times by the time they get to me at age 35, 36, their anti-Mullerian hormone level is like undetectable, or 0.5, or they've had multiple surgeries by different providers trying to help with their pain. And then they're 35, they've been trying for 5 years and they don't have any children. And, I'm kind of the last to see them. And so I think what's important for you guys to remember is that, this is affecting their overall fertility plan. And so whether or not they're thinking about having children early on, they need to be sort of like, they need to be clued in that their disease, I think we always do a good job of saying this could affect your fertility. But what I don't think that we're always a good job about is like how. And that's not necessarily your job. That's my job. Like, my job is to sort of like, all of our jobs, any reproductive endocrinologist that you send them to should be able to say, listen, this is your disease. Your disease is going to affect your fertility in this way. And this is how we can manage it to make sure that you still have the opportunity when and if you're ready to have kids. That's it. So Society for, ASRM recently came out with a practice bulletin that did recommend that anyone with an endometrioma be referred to a reproductive endocrinologist sooner rather than later for evaluation of fertility preservation. So I think that is just, that helps us out because I hate being the bad guy that's like, okay, well now we have to do IVF and like we've got to do like 5 cycles of IVF because we're gonna get like 2 eggs per time. You know, it's just it makes it easier if they have their expectations set early on, and then if at least we've had that conversation with them. So in summary, excision or fulguration of stage 1-2 endometriosis may have like a small benefit for increasing likelihood of spontaneous conception, but not so much that routine performance is recommended. Again, it's personalized care. Like I'm adverse to IVF, I can't do IVF, I can't do fertility treatment, you know, what else can you offer me, doctor? And those are the things that we talk about. There is some evidence that addressing stage 1-2 endometriosis prior to IVF may improve outcomes, but data is too limited. There's no randomized control trial, so we're kind of all just like cowboys flying the wind. Surgical management of stage 2 through 4 endometriosis may increase spontaneous pregnancy rate, but it doesn't appear that more extensional surgeries benefit beyond just removal of operation. So like, again, if you guys are in surgery and you see endometriosis and you're like, it's on the ureter, or oh my God, it's like the entire kind of posterior cul-de-sac. Like, do I need to resect all of that? The answer is probably no. It's probably not making any difference, like whether or not you do any of that. Removal of endometriomas prior to IVF does not appear to improve pregnancy outcomes, but may improve the number of eggs retrieved from the ovary if there's a large endometrioma. The benefit of surgical management for kind of deeply infiltrating endometriosis or colorectal endometriosis remains unclear. Again, I think the take-home message for these patients is, are you trying to get pregnant or are you trying to manage their pain? If you're trying to manage their pain, I tend to refer to my colleagues at Mayo. They do a lot of these deep infiltrating endometriosis surgeries, and their pain improves, but I would not do it for fertility. And then egg cryopreservation should be considered prior to endometriosis surgery if patient is considering delaying conception, particularly if she is of advanced maternal age and has extensive surgery planned or has had an extensive surgery in the past. So if you're seeing this patient over and over and over for chronic pelvic pain, and you've already done a surgery, and they're coming back to you 2 years later and they're like, I'm still in pain. And again, you're still nulliparous, and maybe their partner or not, but these are people that should see an RN. So that is it. Here are my resources. References. Any questions?
So I know that, you know, obviously we're lacking a lot of like evidence-based, you know, like studies kind of things. If it were you, and let's say you were doing diagnostic laparoscopy more for, and you've tried all your things non-surgical, and you're kind of to this point. If it were you, obviously the more aggressive you get at ovarian, you know, like going in and actually removing the whole cyst wall and all that kind of stuff is actually being damaging. If it were you, is there any benefit in your own opinion to draining those more for a pain control? Because it's going to refill.
It's just going to refill within 3 months.
So better off just either leaving them alone.
I think if you're going in and you're trying to sort of, what would you do for pain? I mean, I think that is where I would, you know, we use a lot of interesting techniques. I mean, I don't know whether you've ever sort of like, we can inject kind of vasopressin in the cortex of the ovary and then peel out the ovary laparoscopically. So I think if you're going to take somebody back for pelvic pain with an endometrioma, it might benefit consult with us. Just because, I don't know, there's a lot of new sort of surgical techniques. I mean, it's not anything. I mean, I didn't really do it till I came over to Harlan and was like, oh, this is really cool. So every derm one that I've done, like you can literally laparoscopically with a butterfly needle inject the ovarian cortex, and the cyst literally separates, and then it literally comes out like a balloon. It is the most fascinating approach to cystic surgery that I've ever seen. And you know how hard these endometriomas are. They're like, it's like awful. They don't come out in one piece. They always break open. And I will say that usually even with the butterfly technique, it still breaks open, but like the cyst wall really like pulls off significantly easier. For whatever reason, the vasopressin works to sort of like decrease blood loss, obviously, but it obviously, for whatever reason, it cuts off the blood supply to that cyst, and then like the wall peels off better.
A video of that, how you doing?
Yeah, I know.
Yeah, I can send you guys. Yeah,
Yeah.
there's several. We watch a lot of videos at our
Yeah.
office.
Do
But
you
yeah.
feel like we do a lot of dermoids and?
Do you use much Lupron anymore?
I use a ton of Lupron prior to frozen embryo transfer.
In these patients?
I mean, routinely in women with endometriosis prior to doing an embryo transfer, I'll do 2 months of Lupron. So, and it's because we know that there's just this like microscopic endometriosis, this microscopic inflammation on the endometrial lining that like you can't resect that. It requires medical therapy to sort of really knock down all that inflammation. Right now, Lupron's the best that we have.
Well, I trained during the time when IVF was bad.
Totally, it was
But-
really bad.
But the man I trained with, who was chairman at Georgetown, did a lot of studies for TAP.
Yeah.
And so he was doing resection with, I think was it a sapphire tip for his laser? I mean,
Probably.
and, but he was all about Lupron and that, he was being paid by TAP, but he also was all about Lupron and that, you can't see everybody's endometriosis. And so.
No, you can't. And I mean, there's some clinics in town that do surgery a lot.
Mhm.
And I think for the right patients, it's really beneficial. And I think that it kind of like, you really have to sort of like tease that out. But I think, I don't do a lot of chronic pelvic pain, but what I will say is that I see a dramatic improvement in my patients if I do Lupron for 2 months prior to a frozen embryo transfer.
Well, it's almost diagnostic.
Almost like 15%.
Giving somebody a dose of Lupron, if their pain gets better, that's what they've.
Just talked to somebody yesterday and she was like, the 2 months Zolodex were the best months of my life. I'm like, oh.
I have one quick question. As the MFM, no. You go through this process and what I'm hearing is it's more medical management, help get them pregnant. What do you see for next pregnancy outcomes? Once a woman say you've treated her with Lupron, you've done IVF, she's gotten pregnant, do you see an overall improvement in their ability to get pregnant the next time? Does that tamp down the disease enough?
I mean, I think pregnancy is protective, right? Like
Yeah.
I've seen like 10-centimeter endometriomas completely go away.
Go away, right.
So yes, I think that,
Once you're successful once,
some of you guys know my story. I'm just gonna like be anecdotal here, right? So I likely have endometriosis. It took me 3 years to get pregnant with James. Like finally got pregnant with James. And I come back here and I literally am looking at Megan and Mon. I'm like, all right, well, I'm not gonna spend 3 years trying to get pregnant again. Like I will do IVF, like it's fine. And I got pregnant within a month. So I think that there is absolutely a subset of patients, but I think that all depends on their ovarian reserve prior to getting pregnant and their age. If their ovarian reserve prior to first pregnancy is 0.5 and they didn't do IVF, but they got pregnant spontaneously, and then by the time they're done, 9 months later, breastfeed for a year. So by the time they get back and try to start trying again, maybe at 1.5 to 2 years, like they're going to have a significantly lower pregnancy rate. And it has nothing to do with endometriosis. It has everything to do with the fact that they started off, their vault was lower to start with because of their disease.
So what's the best thing? I won't be doing it, but that we could do to, if you have a patient that you suspect has endometriosis and should we put them on Lupron before we send them to you? Would that be a benefit or no, just leave it alone?
I think the biggest thing that I think the take home message for you guys is, particularly if you see advanced stage endometriosis, you do an ultrasound and there is an endometrioma, which I think we're all pretty comfortable diagnosing and being like, that really looks like an endometrioma. It's a stable, like complex ovarian mass that doesn't change over time. It has the ground glass appearance. Like it's not like this is an endometrioma. Perhaps they have an infertility. Perhaps they don't. Perhaps they're seeing you for just, routine care. I think those are patients that I think in your mind, you should be like, crap, do they have kids? Do they have kids? Do they want kids? And those are people that we should probably be referring to REI. And it's just because by the time we know that endometriosis is progressive, and so if you're not managing their pain with pills or something like that, by the time they get to see me, their AMH is going to be really, really, really compromised. And a baby of advanced maternal age, and then fertility is just a dramatically higher battle.
This is totally off topic, but do you foresee things like Orlissa and Myfembree and those kind of lower dose medications useful in preserving fertility, do you think? So much more for pain control.
The really sad part about it is that the only way to preserve fertility is through egg or embryo cryopreservation. Like there isn't, even with cancer patients, like when I'm seeing cancer patients and they're gonna have chemotherapy, we can offer Lupron, we can offer these things, which is ultimately gonna decrease the metabolic rate of their ovary, and they can kind of go hide from kind of the effects of chemo, but it doesn't overtly support or preserve their fertility.
It's not gonna keep it at, because it's not as strong as, or whatever is Lupron, then you're not gonna see it's dramatic.
But I also just think that there's not really like, it's again, the oxidative damage is there in a lot of endometriosis, and until we figure out what's causing endometriosis, and I think there's probably a genetic predisposition that then is affected by environmental changes, right? Epigenetic sort of changes. But until we sort of like figure out if it's in our water, if it's in our food, if it's in whatever,
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.